Thank you. And I would also like to thank the organizers for inviting me to this wonderful conference and to make this presentation. These are the logos of the various groups that have been supporting the DRIVE study with particular funding from ARNS and NIDA. Okay. I'll be talking about community-supported respondent-driven sampling among persons who inject drugs in HAi Phong, a case study with implications for intervention. This is briefly where HAi Phong is located. It's a city of about 2 million, estimated 100,000 people who inject drugs, 90% of whom are males, 14 MMT clinics, which is relatively good coverage, 3,500 people initiated on methadone. There are 13 ART clinics funded primarily by PEPFAR and the Global Fund. And there are, very importantly, community self-support groups for risk reduction, syringe distribution, community detox, and income-generating activities. Okay. Combined prevention, including needle syringe programs, medication-assisted treatment, and antiretroviral treatment, has greatly reduced HIV transmission among persons who inject drugs in many high-income settings, including Vancouver, New York City, Western Europe, and Taiwan, to where incidence rates are now under 0.5 per 100 person-years at risk. So essentially, the high prevalence HIV epidemics in these areas have ended. It should be possible to replicate these successes in low and middle income settings. However, this will require a high initial investment, but preventing new HIV infections should eventually be cost-saving, that if we invest money now, we will eventually save money compared to not investing money in combined prevention. So what is needed to bring about ending epidemics in resource-limited settings? First, we need high coverage of needle syringe programs, medication-assisted treatment, and ART. But we also need mechanisms to link people who inject drugs to these services. We can't simply expect to open the services and expect everybody will suddenly come and enroll in the services. We need to engage large numbers of people who inject drugs who are not receiving services but are at high risk for acquiring HIV, or if they're HIV positive, at high risk for transmitting HIV to others. Basically, these are people who are injecting very frequently. And we need to provide continuing contact and assistance in obtaining services. We can't expect to see somebody once, do an HIV test, tell them about services, and then just let that person go off by him or herself and successfully get into the services. Getting into services is often a difficult challenge for people who inject drugs, and they need support. They need help with filling out the bureaucratic forms. They need help with reintegrating with their families. There's a lot of assistance that's needed to link people who inject drugs to the services they need. Okay. It would also be desirable to have mechanisms, linkage mechanisms that can be implemented rapidly, because the sooner we can reduce HIV transmission, the sooner we would reach a cost savings point, and it would be very desirable to have mechanisms that are relatively inexpensive. Respondent-driven sampling has been used in over 200 studies that include persons who inject drugs. The HIV epidemic in Vietnam has primarily been driven by injecting drug use. National HIV prevalence is around 13%, possibly slipping down to 10%. However, only one study to date has used RDS in Vietnam, and there is varying level of harm reduction coverage in Vietnam. There is needle exchange, medication-assisted treatment, and ART. Okay, whoops. So our objective was to assess the contributions of community-based peer support groups in support of respondent-driven sampling for recruiting people who inject drugs in HAi Phong, and to consider the implications of peer support groups for implementation interventions. There were 3 peer support groups who participated in this study: Friendship Arms, a support group for people who inject drugs; Virgin Flowers, a support group for commercial sex workers who inject drugs; and White Sands, a support group for MSM who inject drugs. The respondent-driven sampling began in the fall of 2014. We had a target sample size of 600 people to inject drugs. We started with 9 seeds, including 3 MSM and 3 female sex worker people who inject drugs. During the respondent-driven sampling, the peer support groups performed very important activities. First, they provided expert knowledge of the local injecting population. They identified and recruited the seeds. They registered the participants, including validating the RDS coupons and using a fingerprint reader to prevent multiple participation by single individuals. They gave an overview of the study to participants prior to formal informed consent. They determined eligibility, including examination of skin marks or knowledge of injecting practices, and administering a urinalysis to determine if the person actually was currently using drugs. They paid the honoraria, and they distributed the coupons for further recruitment. So the peer support workers had critical roles in interacting with the subjects in this study. They were responsible for developing and maintaining trust between the research group and the participants in the study. We recruited 580 subjects in 3 weeks. Things were very, very busy at the research site. We had up to 50 subjects per day coming into the research site. In addition to the 580 subjects recruited through respondent-driven sampling, we recruited an additional 23 MSM and commercial sex workers. They were also recruited by the peer support staff. Most importantly, we had a low homophily between HIV positive participants and HIV negative participants, indicating that negatives and positives were thoroughly integrated in the population with the possibility of further continued transmission. We required only 5 waves to reach equilibrium on our key measures of HIV status and demographics. So that in terms of a respondent-driven sampling study, this one went very, very well. Within the study participants, 25% of the sample were HIV positive. Using the RDS adjustment, that dropped slightly to 23%, but not a meaningful difference. 67% of the sample were HCV positive. Adjusting for RDS recruiting, that changed to 69%. Again, not a meaningful difference. 91% were male. The average age was 37. Heroin was the drug injected by everyone, and they reported an average of 2.7 injections per day. They clearly were injecting very frequently. They would be at very, very high risk for acquiring or transmitting HIV if they did not have access to evidence-based services. We particularly looked at HIV prevalence among non-MSM male new injectors, persons who had been injecting for less than 2 years. Among this group of new injectors, prevalence was only 1%. We estimated HIV incidence among this group with the assumption that they were HIV negative when they began injecting, and our estimated incidence was 1 per 100 person years at risk. This compares very, very favorably with the Ukraine data presented yesterday, where in the experimental group, HIV incidence was 20 per 100 person years at risk. So the situation in HAi Phong is much, much more favorable towards ending the epidemic than it is in the Ukraine. HIV prevalence was higher among females and MSM injectors, probably due to sexual transmission. So as part of trying to end the HIV epidemic among injectors, we will also have to pay attention to sexual transmission, not just injecting-related transmission. There was already reasonably good coverage of combined prevention and care. More than 80% reported using pharmacies as their primary source of needles and syringes. There are 4,500 positions planned for 10,000 people who inject drugs in HAi Phong. We did viral load testing on the HIV positives. 40% of them were at viral suppression. This is clearly an area where we would like to raise that. The UNAIDS standard is to have basically 70% of people at viral suppression, so there's a significant room for improvement there. But we do really see the possibility of ending the HIV epidemic among people who inject drugs in HAi Phong. We see very low prevalence and low estimated incidence in people who have recently begun injecting, so that there is the possibility, if we can scale up antiretroviral treatment, in particular for ending the epidemic. Okay, this shows the RDS recruitment diagrams. You'll notice that there's only a small number of them, indicating that the drug users there probably form a single large connected network rather than very separate large number of networks, so that we should be able to work with the population as a whole. In terms of integrating RDS and peer support, the RDS study really did rely upon peer support workers. We were able to identify high-risk people who inject drugs very, very rapidly. Again, we interviewed about 600 people in 3 weeks. Both RDS and peer support are relatively inexpensive compared to other ways of trying to locate drug users. And we followed the RDS study with a cohort study where we followed people up for 6 months to look at the role of our peer support workers in maintaining contact with people who inject drugs and successfully linking them to services. And Nicolas Nagot will give a presentation on that. Thank you.
Merci Don.